And then the microphone is right here.
Okay. Should be close enough.
I think this is going to be
Last
close
time
enough.
it sounded good.
Yeah. Hello, everyone. We're going Facebook Live right now.
Hi.
Okay. Okay, Brianne.
Yes.
Welcome.
Thank you.
Can you, in all seriousness, can you just tell me, like, what are your certifications and your background?
So I'm Brianne Huss. I'm a nurse midwife over at Kootenai OBGYN. I work there with 4 other certified nurse midwives, and then we also have Pam Holcomb that was a nurse midwife that's now doing GYN care.
Okay.
So I was a labor and delivery nurse for 13 years and wanted to do more, so I went back to school and became a certified nurse midwife. And then I have a dual certification for women's health nurse practitioner. And with that, all of us, our nurse midwives, we were nurses first, went back to school to get our master's degree.
Okay.
And so it's the highest level of training for midwifery. And we work in the office with the 4 OBs, but we have our own patient kind of clientele that we see, and then we can consult with the doctors if needed. I also have my IBCLC, which is International Board Certified Lactation Consultant, and I received that in 2010. I was working in labor and delivery in a town that didn't offer those services and struggled with my son, Evan, and that prompted me to get my training to do breastfeeding, counseling, and consultant.
That's great.
Yeah, so the hospital has services, but we'll see patients at the office too if they can't get in over there.
Are any of the other midwives?
They're not. We all have training in breastfeeding, but I'm the only one that has the IBCLC.
So your patients can obviously come to you for that, but can
any
other
patients?
Okay,
Yeah.
anybody.
So anyone can call and get in, even as a new patient.
Okay,
to do that.
great.
Yeah.
And then you also have...
And then I also have training for my acupressure for labor support and comfort measures. So with that, I was a labor nurse and working with a lot of the physicians that didn't have a lot of training for natural childbirth. So I went and had training on how to support women during their labor.
Okay.
So there's acupressure points. Some of them are in the ankle and then in the hand that help during labor to decrease pain. And you can do those either for 30 seconds or alternating with every other contraction.
Oh.
There's also pressure point here for nausea. So for first trimester moms, I can show them how to do this one.
Because I was thinking when we were talking before, that it was during labor.
Mostly during labor, but even like first trimester nausea, there's a pressure point here under the collarbone that can help.
And you just press?
Yeah, you press on that or have their partner do it when they're nauseous.
For how long did you say?
Just until the nausea is relieved, up to 2 minutes.
Oh, okay.
So that one's really
I'm
good.
going to remember that.
I know.
I have
I'll have to show you it.
the nausea.
Yep.
Okay.
And then there's one in the wrist too for nausea.
Okay.
And then there's one that we can use to help induce labor. If a woman was, maybe her water broke and she's having just mild contractions. There's one with the sacral joints. We were looking at this pelvis earlier. But some pressure points here in the low pelvis that we can press on to try and stimulate labor.
But you were saying their cervix has to be
right.
Okay.
Yeah, so it wouldn't work if someone's cervix was not ready.
Okay.
If it was thick and not dilating yet. So it has to be soft and ready for that to be effective.
Great.
Yeah.
Okay. So is there anything else?
I think that was all.
I think that was all. Okay, awesome.
Yeah.
So I wanted to start with your certified nurse midwife part. Your clients go to Kootenai Medical Center, and tell me about their baby friendly certified. What does that mean? So
we will see office patients over at the clinic, and then they'll do deliveries over at Kootenai Health. Okay. And the hospital is designated baby friendly. So they have a special certification that's pretty rare. They do a lot of work. The book to pass it is pretty thick. So they put a lot of effort into having this designation. But it means that they're supportive for breastfeeding. So things that are automatic with baby friendly is like skin to skin right after birth. They have that golden hour right after delivery where they want baby skin to skin with mom, and they don't want to do any interventions until the baby has nursed for the first time. So if we need to do a temperature or vital signs, heart rate, things like that, it's done right on the mom's chest. Also, all the midwives are doing delayed cord clamping. So waiting until the pulsations cease after delivery before clamping and cutting the cord. And limiting interventions on the baby and trying to offer as much of skin to skin with mom as possible. And then rooming in is big. We don't have like a well baby nursery.
Okay.
So the baby and the mom are always together.
You don't have to take baby away to do like all the checks and stuff?
Nope,
Oh, that's
nice. They're always together, so it's nice.
Okay.
In the delivery room, the baby's with mom until after that first nursing and first hour. And then we just are like across the room. There's a little warmer there where they would get their weight and their vital signs and things like that.
Okay.
And then if women choose to do medications, it would happen right there in the room with them.
Okay.
And then they move from the labor room over to postpartum.
Okay.
And the baby just rooms in with mom. And they have a little bassinet to keep baby there and encourage feeding on demand.
Okay.
So not setting a schedule, but just watching for those early cues for nursing. And that can be a huge help with establishing a good breastfeeding routine and milk supply. Is following baby's cues. So even though maybe you just nursed 30 minutes ago, but baby's turning head and kind of doing that rooting reflex, those are early signs. Licking the lips, rapid eye movement, and they're coming out of a sleep state. Those are all times to offer the breast to the baby. So the studies show when babies are rooming in with mom, the breastfeeding is more successful.
Oh, good.
And crying is a late sign. So if you waited to feed baby until they're crying, then it's hard. You have to get them calm. So I tell women, like, put baby skin to skin, calm baby down, and then try and nurse from there. Sometimes it's hard. The babies are frantic, and you're trying to get them to latch. And
what are your favorite positions for the new mamas? Because I know
for breastfeeding.
Yeah, for breastfeeding.
So I think initially after birth, this laid back nursing, babies have all of these inbuilt reflexes that are built to make. They're meant to come right up to mom's abdomen, and they do it a crawl.
Yes.
And so if you just give them time at first, they're going to be crying right after delivery, and if you let them settle, then they'll start doing this rooting, and then their feet will start working, and they'll start crawling. And the idea is like for them to show the signs to bring themselves up to the breast.
Okay.
And when the mom's in the laid back position, the baby has a reflex when they're prone like this to be doing this head bob.
Yes.
And searching, and that's their way of getting a good latch. So a lot of women
letting
sit
baby
up
do
this way, it takes away that reflex because they're not face down. So you're trying to latch the baby this way and having trouble. So the first correction is just lay back. Like after delivery, let baby be here, wait for those reflexes to kick in. And they can't help it. They just have to do that head bob and that rooting and searching.
I wish I would have known that because I was having trouble.
Yes.
And it wasn't until I got home and my crotch was hurting.
I know, everything. You're so here.
Yeah, so then I was laying, and it was easier now that I think back on that than sitting up. Well, plus it hurt, so I wasn't able to really relax. But when I would lay down on like the couch, it was easier. So that it makes sense with all the reflexes.
Yeah. I feel like we fight our reflexes sometimes.
Yes.
Like, okay, now we delivered, and we're going to sit up and have this good posture and try and latch baby, and then we have all these struggles that develop from it. Yeah. Like we just go back to the basics of how right after delivery and
it's not just like that first breastfeeding right after delivery. You should do it for
a long time until that.
And that makes sense with what I learned with the reflexes before. Is like let them do those. They're there for survival and to make life easier. I just want to make sure that you're not out of screen.
Yeah.
Okay. Good. Okay.
So I think that's helpful. And then obviously as the latch gets improved and the milk is coming in, then different positions are good.
Right.
Whatever position the mom can be comfortable in. A lot of mistakes I see, like women bringing themselves to baby.
Right.
Like, so baby's here and you're going to bring yourself forward to nurse, and then you're going to be out of alignment and uncomfortable. Instead, you get yourself comfortable and have your shoulders relaxed and then prop. So pillows under the arms and like there's all kinds of pillows and different kind of things to help make it easier, like the breastfeeding pillows and things.
And what are all the different positions? There's like...
So there's the...
I know.
Cross cradle. We'll use that as the baby.
This is
like the standard one where everyone cradles the baby and you see it in all the pictures. This lovely nursing mom. But this is the hardest in the beginning. This is more for babies that have head control and are more developed.
And that's the one we go to first.
I know, because I feel like it's on all the pictures that we see. Everyone's nursing their baby in this cradle hold. Yeah. So I think taking your other hand and placing it kind of below the baby's head, and then using your other arm to support the breast, and that way you can help have some control to guide baby on. Okay. So there's this way, or shifting it under for like the football hold.
Okay. And this is the head, and so like the mouth would be here, and the legs would be coming out
so then
the back.
That would have more support. But once baby's like doing the cross cradle and latched on and doing good, then you can switch and free that hand. Okay. But you don't want to try and latch them on like this. Their head's wobbling everywhere, and there's not good control. So if you take your hand and actually help guide the head on. Okay. And the other mistake is like putting your hand on the back of the baby's head. They also have a reflex to pull back. So if we're trying to place their head on, their reflex will to to pull
so
back.
Keep it at the neck.
Yeah.
Okay.
And like you're holding a piece of fruit at the nape of the neck. So that you're just kind of supporting underneath. So those things will help. And then there's like a sit-up feeding, so you can have the legs straddling your leg and then sitting up this way, and that works really good for preterm infants. And then side lying is a similar thing, so you'd be in your bed on the side and just have baby laying beside you. And I think that's great for nighttime feedings too.
Okay. So since we're talking about breastfeeding, let's just continue. If you start getting those clogged ducts, like those hard and kind of painful, what are your recommendations?
So I think getting a good latch is important in the beginning to prevent complications.
Like a full mouth,
as much of the areola. The baby should have a gape, like a yawn, a big wide gape when latching on, not a small little open mouth and then like slurping the nipple in. That will cause a lot of damage, and the milk won't be let down and exited as easily.
Full mouth.
Full mouth.
Right on the...
And the jaw should drop and the ears should be wiggling. They should have a big full mouthful and the lips kind of flanged up and down. And then to prevent like things like clogged ducts and a lot of nipple pain and even mastitis is preventing nipple breakdown and having a good latch from the beginning. And so that's why I love the baby friendly at the hospital. The lactation consultants are there, and they'll visit every patient that delivers at the hospital and work with them on the latch. And then all of the staff that works there, all the nurses have training in lactation to be able to help moms. And you can also come back as an outpatient after you go home. And even if you didn't deliver at the hospital, lactation services are available. And then the hospital also has donor milk if the baby needs any supplement. So that they don't have to receive formula if that's what the mom chooses. I did not know
that, and that is great. So it's not formula.
Right. So they do have formula or donor milk, and the mom can choose. So I think that's fantastic.
That is
so like
great.
for the babies in the nursery, the NICU, the neonatal intensive care, things like that, that they can use donor milk instead. That's awesome. And then signs to watch for. Usually for first-time moms, the milk comes in about day 3 to 5, and if it's your subsequent baby, it'll be sooner, usually like 2 to 3 days. And just nursing on demand and lots of skin to skin. Skin to skin has been shown to improve baby's growth and neurodevelopment, and then also help with mom's hormones, decrease postpartum depression, and then also help with milk regulation too.
That's not the time to be putting them on a sleep schedule.
Let the baby lead you. They're built to know. And so if you have that baby skin to skin and nursing them on demand and sleeping in the same room with them in the beginning, then you'll be able to nurse as often as the baby needs, and that will tell your body to make the right amount of milk for baby. Clogged ducts, sometimes when some women will hold really tightly supporting the breast. A lot of pressure will prevent the milk from flowing through, and area won't empty out, or just sometimes a little blood will form, or they'll get a clogged duct. So if that happens, there's a lot of soreness. They'll feel some tightness, but there won't be any fever, body aches and chills, or a red streaky area with the clogged duct. It's
like
just
mastitis,
tender, right? Because that will be mastitis. With the clogged duct, doing like a heat pack and massage before, and trying to massage down the sore area when baby's nursing or when they're pumping can help, and just frequent feedings. And I tell women to start on that side when they're nursing to try and get the stronger suck then. And if they angle the baby's chin wherever the clog is,
so even if you're like hovering over them,
even if you lay back and baby's like coming up from on top of you, or
I did that where like my daughter was laying on the bed, and I was literally over her, like her head was
probably this way.
It was like down like that. And I'm glad that you said that. So like angle,
because then the chin will massage it and get that area to release. So I say alternating like positions is important, because then different areas will massage. And then if it's mastitis, it's usually a red hot area to the breast. You'll touch it, it'll be warm.
And that's infection.
It comes with body aches, fever, chills. That's important to get taken care of and not let it go. It can turn into sepsis and a bloodstream infection. Moms can get really sick from mastitis. At the start, if you catch it early, some women don't need antibiotics and kind of push through it. But if it advances, then the recommendation is for antibiotics for 10 days. But getting a good latch and good emptying every feed can help prevent mastitis. So a lot of women will get it even later when they're nursing, maybe when they return back to work. So maybe at 3 months, a mom goes back to work and hasn't been feeding or has been feeding maybe every 3 hours, but then doesn't pump for 6, and that milk is just sitting there not getting drained, and then that milk stasis can cause infection and cause mastitis. So the best thing is frequent emptying all the way, preventing nipple breakdown. Anytime there's a cracked nipple, that's a way for bacteria to be introduced.
What do you say to put on there?
So I think in the beginning, after nursing, is just expressing some colostrum and putting it on the nipple and letting it air dry. And the colostrum is amazing, and so is breast milk. It has white blood cells in it and protective and healing properties too.
Yeah.
So and then air, I feel like not putting the nursing bras back on right away can help.
And not too tight either.
And not too tight either.
Okay. And what do you think about the underwire?
It just is women's preference. Some like that support, but just whatever's comfortable. I think in the beginning, those ones that crisscross are nice. They just pull aside and they give, and they're not too restrictive.
Those. Crisscross?
Yeah, it's just like a really soft, kind of like a sports bra, and like it just crisscrosses over, so you just pull it to the side. There's no flip down.
Oh, I had the flip down.
There's no underwire. And
do you know who makes those?
Expansive. They're everywhere. Like Walmart has them, even Target.
Okay.
I know that they had them at Mother's Haven and Amazon. So they're easy to find. So those ones are nice because they're not going to put pressure points.
Yeah.
The underwire, you worry about it if it's too tight.
Yeah.
Affecting milk flow.
Okay.
And then nipple pain, that's the most common thing that we see with breastfeeding, nipple pain, but trying to work with a lactation consultant or your midwife or provider, pediatrician in the beginning to making sure baby gets a good latch and preventing that nipple soreness and pain. It's tender, but it should not be painful when baby's nursing. Okay. So if you're putting baby on and there's extreme pain when the baby's nursing, then you want to take baby off and try and relatch and get a big mouthful and a deep latch. Try and get as much as the areola in there as possible. And then we say start with the nose to the baby's nose to the nipple, so then when they're latching on, the nipple is going in last. And sometimes that helps. If they start with the mouth to nipple, then it's like rubbing down on the tongue. But instead we want it going in last to the soft palate. Lots of little tricks.
That is. That's great. And then you kind of talked about regulating, like if you have too much or too little, just keep...
I feel like the most common reason women start supplementing or stopping nursing is their perception that they don't have enough milk. And it's hard. We don't have a gauge, and in a bottle you see the baby's getting 3 ounces. Or instead, like... watching your baby is a good way to determine if they're getting enough. You can monitor their pees and their poops. And once your milk comes in, you should be able to hear them swallowing and gulping. Your breasts will be feeling full at first and should feel emptied after a feed. Those are all good signs of a good feed. If those aren't happening, then we would want to investigate it. And if the baby's gaining weight, then that's a reassuring time that there's enough milk. A lot of times the supply decreases when moms go back to work. And there's lots of things to help with that. Frequent pumping is a big thing. And then trying to pump way before starting work. So maybe, a month or so before going back, start doing pumping at least once a day. In the morning, the prolactin levels are highest. So if moms can pump in the morning, they'll get the most volume. Instead of storing early on. That can help. And then oversupply, some women will have too much milk. That, some women will express it and donate it, or others will try and just decrease stimulation and bind the breast after feedings and do ice packs afterwards. I feel like it's harder to manage than undersupply.
Good. That was great. All right, so where were we? I wanted to talk about delivery. And kind of what you do over at KMC, what you're allowed to do, what you're not allowed to do. So if you want to talk about...
I feel like, all of us midwives at Kootenai OB are practicing very similar for delivery. Our philosophy is that physiologic birth is normal and doesn't require a lot of intervention, but there are abnormal things that can come up, so we want to be able to recognize those and monitor for them. So standard, if a patient comes in labor, they would get checked in and triage. The nurses will do 20 minutes of a monitor, make sure that the baby...
external monitor?
External fetal heart rate monitor, and make sure that the baby's heart rate sounds good, and then do an exam if the patient's okay with it and get a determination of what their starting dilation is. And then if they want labor support, the midwife will come in. We'll be there in the hospital doing labor support, so massage, and you have your ball over there like sitting on the exercise ball and laboring in the tub, and hopefully changing your position every 30 minutes to an hour. The idea is getting that pelvis moving and making room for baby. So avoid laying flat in the bed and not moving, because then baby's not going to make its way down the birth canal, but instead doing upright positions with the legs really wide, forward leaning positions, and we could do counter pressure when you're in there, or massage,
squatting. I love squatting.
Walking, lunging like up on a stool, doing the ball, hands and knees. The beds at the hospital are pretty awesome because they do all these great positions. So we'll take advantage of that. We can put the squat bar on, or put women up in this thrown position with their legs really wide and have them leaning over a ball during their labor. Just encourage movement. We try and do intermittent monitoring if there's no complications in the pregnancy, so you're not hooked up to the wires and cables the whole time. And then depending if you're in active labor or not, every hour or 30 minutes, just doing a quick listen to baby before a contraction, during a contraction, and after. And if things sound good, then we wait another 30 minutes and then just do this intermittent listening. And then we want you eating. You need fuel for your labor. So,
so eating and drinking.
Eating and drinking is recommended. Just light, high protein snacks. Usually, or whatever you feel like you have a palate for, avoiding those heavy greasy foods, because sometimes in transition food comes back up. It seems like everything's diverted to the uterus and your bowels aren't digesting well, so anything that you eat sometimes will come back up. We do IV access with a saline lock. Low risk women are able to opt out of an IV if they don't want one. And then women that require antibiotics for group beta strep every 4 hours, it's an IV hooked up and running and have the line connected just for the administration of the IV. And then we unhook them and then they're free from their cables and wires and able to walk around.
And you were saying that you allow women to go 42 weeks.
Up to 42 weeks.
Up to 42 weeks.
If you haven't delivered by 41 weeks, we do offer an induction at that time. And if the patient doesn't want to do an induction, we talk about the risks and benefits both ways. And if they decide that they want to give it some more time, then we would want to do some extra monitoring. I think every 3 days, listening to heart tones and making sure the amniotic fluid level is good. And if everything looks fine, up until 42 weeks. And that's the time we strongly encourage induction. The risk of miscarriage is just higher at 42 weeks and beyond. Or not miscarriage, sorry. Stillbirth.
Stillbirth. Yes. All right, good. So you talked about labor, and you can be in all different positions and in the bathtub, but you cannot give birth in the bathtub.
We don't do water births. No water births, but you can labor in the tub all the way up until you're pushing, as long as you and baby are fine.
Excellent.
Monitor-wise.
Great. And then I was talking to you about vaccinations. And at KMC, you have to sign for them.
So at Kootenai Health, when you get admitted, they're going to ask what you want for newborn medications, if any. So if you're going to decline hepatitis B, vitamin K, or the erythromycin ointment, there's signing and consenting for all 3 of those medications, and then double checking before administering them to the baby as well.
Great.
So there's a little double check. And, if you decide not to do them, there's just counseling on why they're recommended and that you just understand what the recommendation is for.
Great, but that is completely allowed.
It is.
And available. Okay. What were my other questions? Did you have anything else to add to that? Your favorite? Do you have favorite birthing positions with no epidural?
Yeah,
do you have them back on their back for pushing?
So I think changing your position and pushing is important. So even if you start pushing in hands and knees and 30 minutes later you're still pushing, let's rotate you to a different position. I really like side lying or even a tilt. In the room we have the peanut balls. So they're the exercise balls that are big and shaped like a peanut. Have the mom on their side and then their leg coming forward and pushing in that position, and it's just going to extend the opening here of the pelvis and just make more room for that head to come down. I like that position. And then rotating. So maybe side lying, hands and knees. Using
but your go-to isn't necessarily going to be the laying on the back with them.
There's a lot of pressure if women are pushing in that one that's always on TV.
I agree. Yes. And it's the hardest on the pelvic floor because your pelvis is pinned down.
So even if that's an effective push for that patient, trying to wedge them a little bit off to one side or another to protect their pelvic floor.
I like that.
But I think changing the position a lot and trying to be hands off so we don't cause trauma. During delivery, we'll typically do warm compresses and then also mineral oil, just to decrease the tearing of the tissue. And try and think what else. Just listen. Women that are unmedicated, don't have an epidural, we encourage them listening to their body and bearing down as they feel it. There's that reflex that will kick in and tell your body kind of how to take over.
So no purple pushing and stuff. It's follow your body. That's great. I love that. All that. Let's go to when women are pregnant. What are your activity restrictions? So I'm pregnant. I'm not pregnant, but if I was, and I said what can I do? What can't I do? I do CrossFit. That's really what I do.
So women that come in, whatever their exercise routine normally is, we'll typically have them continue it.
Okay.
We don't put in weight restrictions or anything like that, but no contact sports. So if you need to wear a helmet for it, you avoid it in pregnancy. No downhill skiing or horseback riding or things that can cause an injury or blunt trauma. As far as weight-wise, just being cautious with overhead presses and lifting. That relaxin hormone will kick in, and then your center of gravity is thrown off, you know, when you are a girl and baby. Yeah. So just using a lot of caution and really reinforcing good body mechanics. But if you're crossfitting and want to continue it your whole pregnancy, I think it's great, and listen to your body. Great. And then just avoid getting overheated. We don't like have a certain pulse. I think the talk test is great. Yeah. Like if you're working out and you're striving for air,
it might be a little bit.
Then we say tone it down a little. But if you can carry on a conversation or like have a sentence, then that's an adequate level. Okay. And then hot yoga should probably be
I've read
cut down. Yeah. There's warm yoga and hot yoga. The Bikram yoga is too hot, and they're getting overheated, and that can affect the development of the baby.
And that's actually, we were talking about some of the recommendations are not research backed, but the ones that are research backed are like no scuba diving. No contact sports, no hot yoga is one of them. So, like, it doesn't say don't lift 30 pounds. No. So don't tell your ladies don't lift 30 pounds.
If you have never worked out in your life, I would say don't go start doing heavy weightlifting. Exactly. Start with walking and yoga and increase slowly from there.
I like that. Okay.
And I think pregnancy is such an important time to focus on good nutrition and exercise. There's studies that support women that are getting regular exercise have a decreased rate of induction during their pregnancy and complications like cesarean section. And that's another thing I think we're going to talk about is what we can do as midwives, certified nurse midwives at the hospital. So we take care of mostly low-risk women. Okay.
What does that mean?
Women, if you were diabetic before pregnancy, then that would probably be too high risk because the blood sugars are affected in pregnancy. Or if you had high blood pressures before pregnancy, then probably that would be a patient that we would refer for the doctors to see. But women who develop gestational diabetes and it's controlled by diet, or high blood pressure at the end of pregnancy that's controlled, we can keep seeing those patients. Women that have a history of having a C-section, they are able to see the physicians and do a VBAC, which is a vaginal birth after cesarean. And so they can trial labor at the hospital. And one of the doctors will be there the whole time that they're in labor and give them the opportunity to have vaginal birth even though they've had a C-section before. So I'm excited that Kootenai Health is offering VBACs.
Is that new?
I feel like new-ish. Maybe 2 years or so.
But they do have the C-sections, and they're still like baby friendly and all that.
And so even if a patient has a C-section and there's no neonatal emergency where they have to go to the ICU, neonatal ICU, baby will go skin to skin in the operating room and follow mom, like be on mom's chest, wheeling into the recovery room, and they stay skin to skin and rooming in the whole time. So I think that's the great thing about baby friendly. I
don't think all of the hospitals allow that. It's very
I love that they get
great.
To be with their moms, and that's really a little bit newer too. With the new unit. I was trying to think what else. So we don't do vacuum or forceps deliveries. If that was a need, then we would call the physicians in. The midwife group has a low rate of C-sections. I feel like the national average is in the 30s, and ours is probably 10 to 15%. So it's a lot lower. We don't put time frames on a lot of things. If your water broke, we don't give you 4 hours to go into labor.
I had that. Yes. And I was telling you, it was very stressful for me. So I was like, but everything started naturally, and they were telling me this, and I still had nurse midwives, and I was like, I was stimulating everything like you were talking about, and everything worked out fine, but it was stressful.
So sometimes that's something we can offer is nipple stimulation. Maybe hook up the breast pump 2 minutes on and off, and see if we can get labor to go on that way, and give it some time. As long as there's no sign of infection, the fluid is clear, baby's doing well and moving. And then also for labor, so maybe you've been 5 centimeters for 3 hours, we'll still give you more time and try different positions and rest and food and things like that to see if we can get it.
Perfect. Encourage it. There was something that popped in my mind that I was like, we were going to talk about
that.
Was
it sutures?
Oh, yes.
Repairs.
Sutures.
And so we do repair. So if the skin just breaks, we call it like an abrasion. So like if you skid your knee and the skin breaks a little bit, sometimes that'll happen as the head is passing through.
Yes.
So that, as long as it's
finger
not bleeding, or finger,
mine
or
elbow.
Finger, those little babies.
They come up like right at the end.
And then the elbows can be damaging. But if it's just a little abrasion, then we don't do repair as long as it's not bleeding. And then if it's a very small first degree, some of those don't need a repair. But if it's bleeding or extensive, then we do sutures, and we do first and second degree repairs. But if it's through the muscle or into the sphincter, the rectal sphincter, third or fourth degree, then we call one of the doctors in to
because
do that
really is major surgery and very fine surgery where they need good lighting, and it's one of those.
And you can see the effects of them after. It's really important for it to come back, the muscles to come back appropriately, and for their pelvic floor to heal properly.
And I was telling you this before, my preference, I like when you guys suture because it gives me these fine lines instead of like all this funky rolling and rippling and stuff. So it helps me as a pelvic floor physical therapist to see those stitches and to see things coming back together. So that's
and
great.
Then we'll see women 2 weeks after delivery, and it's just mostly like a mental health check-in and make sure this adaptation to new baby is going well, nursing is going well. We screen for postpartum depression. A lot of times their support person has gone back to work at that time. Make sure that they have a support system in place and address any issues. And if they had stitches, we can take a look and make sure those are starting to heal well. And then again at 6 to 8 weeks after delivery, and that's when we talk about birth control, and then look at the stitches, and then also do an assessment for the diastasis. Good. So we'll check at that time, and then clear for exercise and what's appropriate for them to resume doing. And then also we can evaluate their pelvic floor too. So we can look for them to see if they have, if they're having a leaky bladder, or if they...
and you're looking at prolapse too,
we're looking for prolapse as well.
Good.
Both anterior and posterior.
Great.
Yeah. And then we'll start talking about exercises. So I've learned a few for you, from you, and the videos you've posted. I think are great. The bridge is good. And just starting with
just so low impact.
Low impact, and just kind of working their way up from there.
Okay. I love that.
Yes.
Did we cover everything?
I don't know. I can't remember.
Positions, suture, exercises, postpartum checks. Yeah, I think we did.
That's good. And then something that we didn't talk about before, but I think is exciting, is we are doing group prenatal care.
Oh, okay.
So with that, traditional prenatal care, you come in, you meet with your provider, and then once a month you come for your appointments. They're approximately 10 to 15 minutes long.
Okay.
You don't get a lot of education, so women are supplementing that by going to a childbirth class at the hospital.
Okay.
And doing, a series of classes. But with group prenatal care, you would have your initial visit one-on-one with the midwife. And then, we'll order the initial labs and everything. And then you would, the next class, come to our post-falls office. You'll meet with the midwife just for a few minutes. We'll listen to baby and measure the uterus, answer any questions or concerns you have, go over lab results, and then you'll go to our conference room. And then join all the other couples, do the same month. And then we spend 1 to 2 hours going over education that's appropriate, either first trimester, second trimester.
Great.
And in that, we're including labor and delivery. So we're doing childbirth education, comfort measures, pain relief options, positions, do a lot of like guided imagery and breathing techniques, things like that. And then also include a lot of education on breastfeeding and newborn care, and then birth control options, postpartum recovery. And then the women all come back after they've had the babies at 6 weeks and get to see everybody.
Oh, that's great.
Yes, and it's been so great. And I feel like we get a better bond. We're really connected to those patients. And then they're developing this little community, which is amazing.
It is. And you need a community.
Yes, I love it.
That support.
There's a group recently that they get together once a week and have brunch.
What?
They've all delivered.
Oh my gosh.
I know. So it's just awesome to see that expansion.
That is awesome.
So, yeah, I think it's a pretty cool thing that we offer.
That is great.
Oh, that's good.
Well, great. Yes. I should see if anybody has any questions.
Yeah. See if we have any questions on there.
Yeah. Let's see. Nothing right now. Okay. Well, let's just sign off then, and if they have any questions, they can post something. Yes. So thank you so much.
And we're always happy to do a meet and greet if someone's considering if they wanted to come and they have certain questions about their delivery or
in a tour.
The hospital tour. They do those. You just call Kootenai Health, and they'll get you set up. I think it's like Wednesday evenings or something like that. Great. But they have scheduled tours, and then anyone's available to to schedule appointments for lactation visits, and then we do annual exams and GYN care, birth control. We see women throughout.
So you don't
their
have to just come to you. Just if you're pregnant.
Yeah, we see women throughout their whole lifespan. So sometimes we'll act as primary care providers doing annual labs and thyroid panels and things like that if needed as well.
Okay.
I had another thought of something that we were going to mention. Ultrasounds. We had talked about ultrasounds.
We did talk about ultrasounds.
About the frequency of ultrasounds in pregnancy.
What are your frequencies?
So women that come in and have a certain last menstrual period and are certain on the date of conception and have accurate dating, they don't need one early on. So maybe their only ultrasound would be at 20 weeks. It would be an anatomy ultrasound, kind of head to toe screen on baby, and then looking at placental location and fluid around baby as well. Otherwise, we would offer a dating ultrasound around 7 or 8 weeks, and that just confirms how far along the mom is to establish an accurate due date. And then we offer all women genetic testing to screen for risk for genetic abnormalities and Down syndrome. That would be a nuchal translucency ultrasound, so checking the thickness of the baby's neck along with a blood test, checking proteins in the mom's blood. If those are abnormal, it's just a screening, which would require further evaluation for a diagnosis. So that would be a second ultrasound before 14 weeks, and then their 20-week anatomy ultrasound. So 3 would be the most that are typical.
Okay, great. I was going to ask, do you, if women don't want to be checked at all. Is that okay? Is that something that...
So we don't, like, during their prenatal visits, we don't routinely do vaginal exams.
Great.
It's not standard.
It's not standard.
No, but a lot of women are curious or want to know, so it just, if they want one, then we can do one. But otherwise, I feel like it doesn't change the plan of care. We might check you in your 39 weeks and you're 1 centimeter and you have a baby that night.
Yes.
Or you could be 4 centimeters and not deliver for 2 weeks. So it doesn't change much.
I opted out of mine because it was standard care. And so my first one was after my water broke in the hospital. And I feel the same way. Like, if it said, if it was like 5, then maybe I would have got my hopes up and I still hadn't delivered or something like that. Another thing I was going to ask you is the glucose test. If they want to opt out of that and just prick their finger every day, is that allowed?
Wouldn't probably go directly to that. We have a little form that has risk factors. So it's based on age and ethnicity, family history, history of diabetes or not, history of a large baby or not. All these risk factors. If you don't meet any of those risk factors, you're probably low risk for having gestational diabetes. And so at that time, if you wanted to not have the screening, I think it would be reasonable to
so that's allowed. What if you never had a baby and you...
Yeah, so that one would be hard to tell. So we have that conversation. I think that gestational diabetes is something that has a lot of complications in pregnancy if not well treated. So it's one that's easily treated with exercise and diet. But some women will opt not to do it and we can do like a fasting blood sugar, or they can get the AccuCheck monitor and do some screens at home and track what it is.
So there's some, you guys have some leeway.
And then if they have an abnormal glucose test, then typically diet and exercise is all it takes to keep those blood sugars under control, and learning how to pair your proteins with your meals and carbs and things like that. So
great. Okay, good. Was there anything else?
I know.
That was all. Those are the last minute. And there is. And yes, if you're a new mama, I feel like all these questions come up, and this is nice.
Some support groups for new moms that are coming. So I'm going to try and share those on Facebook as they come about. And then there's some lactation support groups that are developing. So I feel like there's a lot coming.
There's a lot of support.
And, some support happening in the community, and trying to connect with other women that are having babies too, because you guys can help each other through, which is important.
Definitely. All right. Well, thank you so much.
It was nice chatting with you.
It was nice chatting with you.